Sir, can we wait for 2 minutes so that if more participants could join?
Sure, we can wait for 2 minutes, not a problem.
No, sir. We'll start by, I think, 8:05, sir.
Okay, no problem. That is fine.
We can start, sir.
Yeah, I
Anish,
think
sir,
now
you're
it's
not.
audible.
Yeah, yeah, sir. Now it is audible.
Yeah. So we'll start the session, and the presentation is seen or
Yes, sir. Yes, sir. It is seen, sir.
okay, perfect. So welcome everyone for this session of Shine. The topic for today is neonatal sepsis. So it is a very important, very common topic that we see on a day-to-day basis. The objectives for today's session is to first identify all the newborns with sepsis. So how do you recognize and diagnose sepsis? Enumerate the important organisms, interpret the ever confusing sepsis screen, which is a lab test, and then how to treat neonatal sepsis. So we'll try to go through these step by step and try to identify things which can be managed by clinical diagnosis. So neonatal sepsis is a clinical syndrome which is characterized by signs and symptoms of infection, which with may or may not be have accompanying signs of bacteremia, which is seen in the first month. So neonatal period is the first month of life. So whatever infection that happens in that period is called neonatal sepsis. By chronology, we classify neonatal sepsis into two categories. One is called early onset sepsis, which means the sepsis symptoms have appeared within 3 days of birth. And the other is late onset sepsis, which the symptoms start after 72 hours of birth. So this is important for a few reasons. One is that you want to know what antibiotics you want to give, how severe it is going to be, what is the course, is it predictable or not. So for early onset sepsis, the bacteria has, transfer of bacteria from to the baby has happened during the perinatal period, which means just before delivery, probably around delivery time, or maybe even just after delivery. So the commonest source is the maternal genital tract if it is a vaginal delivery. And the usual clinical presentation for early onset sepsis is respiratory distress. So Congenital pneumonia, what we call, is very common. And the transmission, like I said, is vertical, either in utero or maybe intrapartum, which is during delivery. Late onset sepsis is something that the baby has got after birth, and that is why the symptoms started after 3 days. And the source of organism can be anywhere. It could be the hands of the caregiver, it could be the home environment, it could be the hospital environment. And the symptoms are a little different. The early onset sepsis, like I said, pneumonia or respiratory symptom is common. Late onset sepsis can have, focal infection. It could be a pneumonia, it could be a meningitis, it could be a urine infection. So different presentations can occur. And it could either be nosocomial if the child is in the hospital, or it could be acquired from the community or at the home. So by chronology, typically if it is within the first 3 days, we call it early onset sepsis. Beyond the 3 days, it is called late onset sepsis. So for early onset sepsis, what are the risk factors? So which babies are more prone to catch early onset sepsis? These would be babies who are preterm, so their immunity is low. They are low birth weight. If there is, prolonged rupture of membranes, so the bag of membranes protects the fetus inside the womb. So if that is broken for 18 hours, 24 hours, then that is a risk factor that, some external or some organism might reach the baby. If there is prolonged labor, foul smelling liquor, multiple examinations, vaginal examinations, so the baby can get infected there. Maternal fever. So, a lot of factors are there which put the baby at a higher risk for early onset sepsis. Maternal tachycardia. So, a lot of features are there which we need to monitor and ask in the history that did the mother have any of these risk factors. And especially in preterm, we need to first ask that why did preterm labor start? Because many times preterm labor itself may be a sign that there is some mild infection or subclinical infection in the mother. Late onset sepsis risk factors are either related, to the environment. So if we are thinking about a baby who's in the nosocomial or hospital environment, we have to look at factors inside the hospital. Like, is the baby having frequent pricks? Does the baby have a central line? Is there a poor skin integrity? Are there, multiple courses of antibiotics that the baby has received so that there is some fungal, infection or a resistant infection? Is there good hand washing happening? So whenever you breach the mucosa or skin, there is a chance that the bacteria enters the baby. Poor nutrition. So if the baby is having delayed nutrition of feeds, prolonged periods of full feeds, which means longer IV fluids, breast milk provides a lot of immunity to the child. So if the baby is not breastfed, that also acts as an extra risk factor for the baby. So these are general risk factors. So early onset risk, sepsis risk factors. Think of maternal chorioamnionitis, which means inflammation of the placenta, fetoplacental unit. So there, in that case, even the mother might have some symptoms like fever, tachycardia, maternal CRP counts might be high. And there could be some risk factors related to the pregnancy, like a prolonged rupture of membranes, prolonged labor, multiple examination. Late onset sepsis, think of, risk factors from the environment. Like, is the baby in the hospital? Are we breaching the skin, mucosa, something like that that is happening? Or if the baby is not getting nutrition at all, that could be a risk factor. Coming to clinical risk factors, because newborn babies can't speak, they can't express themselves, they can't point at any pain. Majority of the clinical features of sepsis are general features, which are also sometimes called as non-specific features or non-specific symptoms. So they could represent anything. So refusal to feed, not arousable, which means drowsy, comatose, having a very poor cry, not gaining weight, having abdomen distension, vomiting, even loose motions, poor perfusion, having shock, bleeding. So these become all general features. They don't point to a particular area. And the reason also why babies don't have that is because of their low immunity. Their, immunity is not compartmentalized. So like if I have a chest infection, probably I will have a cough. But a baby with, pneumonia can have shock, can have, if the congenital pneumonia is severe, can have poor perfusion, can also have secondary, poor activity, can become drowsy. So they can have generalized symptoms very easily because of their immune response. So general symptoms are probably, I would say, by far the most common symptoms for sepsis. Suggestive of pneumonia, there could be fast breathing, retractions, grunting, apnea, cyanosis. If if we suspect a late onset sepsis with meningitis, there could be fever, seizures, staring look, high pitched cry, irritability, net retractions. There could be a bulging fontanelle. Diarrhea is suspected if there is watery stool or blood in stools, which is also a red flag or a warning sign. Sclerema means that the skin feels woody hard. So what happens is that the subcutaneous tissue becomes calcified and hard. So that presents as a diffuse hardening of the subcutaneous tissue, resulting in a tight, smooth skin that feels bound to the underlying structure. So when you pinch a newborn baby's skin in the neck or on the tummy, on the chest wall, you feel that the skin can be very easily pinched because of the subcutaneous tissue. But in sclerema, what happens that the subcutaneous tissue becomes hard. So that is a sign of severe sepsis, or that is a late sign. Similarly, AKI or acute kidney injury and renal failure are signs that there has been multi-organ damage. The child stops passing urine, there is edema, excessive weight gain, oliguria, and urea. So typically sepsis, which means, the infection or bacteria is in the blood. It is not confined to a single organ. So majority of the symptoms are generalized. Poor feeding, lethargy, you can think of, you can picture a sick baby as very floppy, tired, lethargic, grunting in between. Temperature instabilities will be there. There might be bleeding when you put IVs. So poor perfusion, off color, baby might appear off color. And as it progresses, it can have, individual signs of any system. So from respiratory symptom, there could be tachypnea, distress, or even apnea with desaturations. From the cardiovascular standpoint, there could be shock. Abdomen, there could be abdomen distension, loose stool, blood in stool, recurrent vomiting. Renal system, it could be oliguria, anuria. And CNS, we already discussed, it could be either very severe lethargy, comatose, or not responding, or it could be irritability, seizures, and blank look. So all these symptoms we should have in mind as a symptom of sepsis. But then if all these symptoms are there, then we will just end up, overdiagnosing sepsis. Everything will seem like sepsis. So then what do? We need to diagnose it. So there are some tests that will help us diagnose. So one is the direct method, which by which we, say that, okay, let us find the organism, let us grow it in our lab, let us identify it, which organism is it, and let us put it for a culture sensitivity. So that is the gold standard or the ideal method, which is called as a culture sensitivity testing. So there we isolate the microorganism from whichever site we feel is likely to be the culprit. So blood is usually the commonest. We always take a blood culture because there is clinical sepsis, and like I said, the bacteria, multiply in the blood. And in quite a few cases where we doubt that, any other site will also give us a better yield, we take a sample from there also. So CSF, urine, pus, sometimes even, umbilical swabs we can take if we suspect a sepsis. Because whenever we can grow an organism, it helps a great deal in titrating our antibiotic choice. So that is very useful if we can pinpoint which organism it is. It can also help us in choosing the antibiotic, but also in the duration of treatment. So blood culture is considered the gold standard for diagnosing sepsis. It should be performed in all cases of sepsis prior to starting antibiotics. So that is very important because once you give an antibiotic shot, you wait for 2-3 hours or a few hours, the bacterial load comes down drastically, and our culture methods are not able to pick it up. A few things about the culture. So this is a Bactec bottle that you can see, which has a liquid culture medium. So this is very important because this acts as a special medium where bacteria can grow easily. And the blood volume is also important. So typically we say that at least, for a preterm baby, you should take 1 ml. And for a term baby, you should take around 3 ml of blood for a culture, so that there is a higher chance of growing the organism. There are many instances where the blood culture may not grow, an organism, and clinically you may suspect sepsis. So we'll come to that a little later, what can be done. But basically a positive blood culture along with the sensitivity pattern is the best guide for antimicrobial therapy. Coming to indirect methods. So suppose you have sent the blood culture. Now there are two problems. One is that the blood culture is, taking 2 days or 3 days to come because the culture test, you put the bacteria and it grows. And the second thing is that sometimes the blood culture may not be, positive because either the child has received antibiotics from some other hospital, or the bacterial load is not good, or maybe the sample was not sufficient. So you need to have some more, markers. You feel that the baby has sepsis, but the culture is not showing anything. So what can we do in the meantime? What we can do is we can send what is called as a sepsis screen. So now these are indirect tests, and they are usually a combination of parameters, because a single parameter is not reliable. So these are sort of screening tests. They are not confirmatory, and you do it only when you suspect sepsis clinically. So the golden rule of sending a sepsis screen is never send a sepsis screen without a reason. Like only if you feel that there is some major suspicion clinically, then only send it. Because there are many false positives. It is a screening test, so it has lot of false positives. So even if the baby is, say has meconium or some other stress going on, or post-operative babies will have a high sepsis screen or a positive sepsis screen. So the sepsis screen is not specific for sepsis. It can be, elevated in any stress or inflammation for the baby. So we should not rely on these markers alone, and we should send them only if first clinically we are suspecting that there is some problem. So what are the components of sepsis screen? Total leukocyte count, which in common terms we call as WBC count. So in adults, we typically consider a very high count as abnormal. In newborn babies, preterm babies, we consider leukopenia or a low count as abnormal. So less than 5,000 is not good. Out of that, absolute neutrophil count less than 1800 is considered low. IT ratio more than 0.2, so that is your proportion of immature cells. So if your immature cells rise, that is also a bad sign. Micro ESR more than 15 and CRP more than 10 mg per liter. So when you combine all of these and when you send all of these, they have a reasonably good sensitivity to screen for sepsis. And if suppose you do all of that and they come negative, then you can also be reassured. So they have a reasonably good negative predictive value, so that you can be reassured that sepsis is less likely. So this is one thing that will help. And if two or more parameters are abnormal, then you consider the whole screen as a positive screen. And as it is mentioned in the green, highlighted text, that a neonate with positive sepsis screen may have the infection, or it could be positive due to any other reason like inflammation, meconium, stress, or so forth. Even post-vaccine sepsis screens have known to be positive post-vaccination. So you should firstly send a test only when you suspect sepsis, and more than two parameters, then your likelihood of having sepsis increase. So you should think of it as a more alarming or a more critical sign for deciding the treatment. So when you think of it, so just taking a step back and thinking of diagnosing of sepsis, you think of it as a threefold or a three filter phenomenon. Number one is I ask a very good history, that okay, did the mother have fever? Was there leaking? Was the mother had tachycardia? Mother's counts? Was there prolonged labor? Was there PPROM? Is the discharge foul smelling? Is the baby preterm term? Does the baby have a central line for late onset sepsis? Have there been multiple pricks? What center has the baby been referred to? So this is my risk factor assessment, which is my filter number one. Second and the most important filter is the baby's clinical examination. So then immediately I go to the baby, I do a thorough examination. Is the baby dull or active? Is the baby, responding, sucking, reflexes are all good? What is the breathing, saturation, everything is perfect. How is the perfusion, heart rate? What is the urine output? So overall, I develop a clinical picture. And third is the sepsis screen. So these are my labs that help me. So I have a three-pronged approach to diagnosis sepsis. If you ask me what is the most important, obviously the most important is what the baby tells you. Baby is looking very lethargic. There is bleeding from some sides. The baby is breathing, grunting. There is a risk factor. Mother was leaking. So then you don't even, need to rely on the labs. So always remember that the baby's symptoms are the primary thing. Second most important is the detailed history and risk factor assessment. And probably along with that, as a supplemental test, it will be the sepsis screen. And in early onset or late onset, it is always a mix of these three things only. There is no fourth thing that you need to worry about. So always risk factor assessment, clinical exam, labs. And all these go hand in hand. Okay. So when do you do lumbar puncture? So lumbar puncture is when you suspect meningitis. Again, many babies may not have symptoms of meningitis. So there is one golden rule. Early onset or late onset, whenever there is a culture positivity, you must do a lumbar puncture. whenever you have a blood culture positive sepsis, lumbar puncture is always indicated. For early onset sepsis without a blood culture positive, you can avoid a lumbar puncture. For a late onset sepsis, which is clinically, you are quite certain that there is late onset sepsis and you are going to start antibiotics, always perform a lumbar puncture. Okay. So for late onset sepsis, the incidence of meningitis is higher. So prior to starting antibiotics, it is always recommended that you do a lumbar puncture. For early onset sepsis, you have an option that, if the culture is positive, you can do a lumbar puncture. If the culture is negative, then maybe avoid. But again, nowadays, if it is early onset sepsis, culture negative, but the clinical picture was like a severe sepsis, we do lumbar puncture. So I think if clinical doubt is more very severe and you want to treat it, then always better to rule out meningitis. Solely for one reason, that the treatment duration changes. So if you have not ruled out meningitis, then stopping antibiotics early becomes a little bit of an ethical dilemma. So it is always better to do lumbar puncture if you have strongly suspected sepsis, and more so in late onset sepsis. Management of sepsis, again, we'll go through that in very brief. So the first priority is always for stabilization. So this baby is septic, drowsy, not breathing well. So first maintain TABC. Everyone knows the full form: temperature, airway, breathing, circulation. So first focus on all this. Ensure optimum oxygenation. So our oxygen targets are 91 to 95%. Maintain normoglycemia. So ensure that the sugars are fine. You can give vitamin K because that helps in, the coagulation parameters. If the baby is hemodynamically compromised, like is on inotropes, off color, or, not looking well, anuric, then better to hold feeds because that is an additional task for the baby. And if there is sclerema, then you need to be more watchful. You need to be very careful if there is sclerema. That suggests an advanced sepsis. So exchange transfusion, IVIG, these are all adjuncts with limited role, but those things can be considered whenever you think of a life-threatening sepsis or sclerema. So what is an antibiotic policy, or what antibiotic policy should we have? So till cultures come. So suppose I strongly suspected sepsis and I have sent a blood culture. But obviously I need to start something because, 48 hours is the time that, minimum time that culture reports take to come back. So my choice of antibiotics will depend on whether I'm suspecting early onset sepsis or late onset sepsis. And depending on that, whether the bacteria are mostly maternal vaginal tract bacteria or some hospital acquired bacteria. So depending on that, we do. It is always good to have an antibiotic policy for every hospital, because if with it shouldn't be that 5 different doctors are starting 5 different antibiotics, and there are certain conditions where antibiotics are not needed unless there is some additional risk factor. The reason this is listed is that these are common reasons why doctors like me start antibiotics. So if it is a meconium stain, or meconium aspiration syndrome, routine antibiotics are not needed. Baby is having only respiratory distress, respiratory symptom, that is due to the meconium. So no need to start antibiotics. RDS in a preterm baby. So baby who's born at 30, 32 weeks is needing CPAP because of grunting. That is expected. So that is again not a sign of sepsis. Birth asphyxia. So if there is no maternal risk factors, nothing is there. If it is an asphyxia, that again by itself is not an indication for sepsis. Jaundice, prematurity, heart disease. So all these are not factors where we need to by default start antibiotics. What we need to do we need to leave them alone? No, we need to see for clinical signs. So suppose it is a term baby who's having unexplained distress, then my thought goes to congenital pneumonia. Then I dig into the history risk factors. Oh, this mother was leaking for 2 days. Mother had a bad UTI. So then, okay, so that's a different story. So by itself, these conditions may not warrant antibiotics, but that does not mean that we don't miss out on the other 2 parameters that I said: detailed history, clinical examination, and lab markers. So we always go for that triad of the approach for sepsis. When to stop antibiotics is important because we all know how to start it, but then we don't know when to stop it. So again, in your mind, you should be very clear. Suppose the baby was not symptomatic. You started the antibiotic because of the history. Mother had a very long leak, say 2-3 days leak was there. Baby was born. You immediately send the culture and started. Baby was happy, not on any support, very stable, full feeds. So for those babies, you can stop antibiotics very early, which means within 36 to 48 hours. So as soon as the preliminary culture report comes, you can stop that. Okay. Symptomatic baby who had a positive screen. So suppose the baby had a minor or a transient symptom like respiratory distress, or initially had some transient circulatory disturbance, but you notice that in 48 hours the baby has just turned around and become very healthy. Culture also came clear, but this baby had a doubtful symptom, so you don't want to stop it at 48 hours. So you can give it for a what we call as a short duration antibiotic, which is 5 to 7 days, because this will be called as culture negative sepsis, but they were symptomatic, so we are still calling it sepsis. The first case will not be called sepsis. That was just prophylactic antibiotic based on the risk factor, or or a positive sepsis screen. So that was a screen positive sepsis. Here it is a presumed sepsis, which is culture negative. And the third scenario is which is a culture positive sepsis. So culture positive sepsis, if it is a gram positive organism, typically, you can give for 10 to 14 days. If it is a gram negative organism, then you need to give for 14 to 21 days. But for meningitis, you need to give for 3 weeks. And for meningitis, you might need a little more in-depth evaluation. You want to see if there are no complications of meningitis, no subdural empyema, no ventriculitis. So before stopping antibiotics in a case of meningitis, you might need to do a few more extra steps to ensure complete clearance of the bacteria. So basic principles of what is antimicrobial stewardship? Stewardship simply means that rational use of antibiotics. Sometimes you get referred cases. Day one baby, they have started meropenem, vancomycin and amikacin. So it is like a very heavy approach. They were just, out of panic, the pediatrician has started without any rationale. So that becomes very difficult, because what will happen is that soon, like MDR TB has come, XDR TB has come, that, the tuberculous bacteria is resistant. Very soon you will start getting MDR neonatal sepsis. In fact, once in a while we do see that also, that the baby has a sepsis, Acinetobacter, which is resistant to majority of organisms. So it is very important that we practice antimicrobial stewardship, which means that very timely and appropriate use of antibiotics. We select a regimen, we select an optimal dose duration, we know when to stop it, and we follow all the steps of it, like there is a policy. So this usually happens in if there is a team. If I have to decide, if I am the whole and soul to decide, then it is very difficult to, have that vision or clarity. So it is always better if somebody from microbiology or somebody from, say, some other team comes and also checks, okay, this baby has been started on higher antibiotic. So why have you started? How long do you plan to treat? And what is your scenario? So I think we will go through the interesting part of this discussion, which is the case scenarios. And I want everyone to type their answers also, so that it can be a little more interactive. Okay, so the case one, this is a full-term baby, 38 weeks, 2.850, so AGA, appropriate for gestation, vaginally delivered, primiparous mother, there was meconium stained liquor, no other risk factor for sepsis, baby cried after birth, Apgar score is 7 and 8. Meconium stained liquor, and baby got admitted with respiratory distress. There is a moderate distress. The Downey score is 5/10. On transfer, the temperature, airway, breathing, circulation was okay. And because of the grunting and the Downey score, the baby started on CPAP. Reasonable CPAP settings, PEEP of 5, FiO to 30%, and saturation is 94%. Now, what is the next thing we should do? How many people want to do a sepsis screen? How many people want to start antibiotics directly? How many people are comfortable to not do anything? And who will want to give feeds? So everyone, please type the answers. Let me see if I can see the chat box. Please post your questions, everyone. So this is a very straightforward case. I think something that we see on a day-to-day basis. Term baby meconium, and like
So
has
we have
distress.
one
So the
answer, sir. No antibiotics needed.
no antibiotics are needed. So that is correct. And do you want to send a sepsis screen or not send a sepsis screen?
Somebody has replied, no need for septic screen and antibiotics. We can start with feeds.
Very good. So again, like I said, no, there is a golden rule. So this is a symptomatic baby. So that is why there is a little bit of confusion. This baby has a symptom. In your head, what do you think? Are these symptoms explained by a reason? If these symptoms are not explained by any reason, then you blame it on infection. So this baby has a good reason for having a breathing difficulty. There was meconium stained liquor, X-ray suggestive of MAS. So there is a reason. So you know that the respiratory distress is related to meconium. So there is no sepsis screen required. There is no antibiotics needed, but the baby has to be monitored for worsening respiratory distress. So, like a meconium stained aspiration syndrome, if the baby improves in 2, 3, 4 days, then you are happy, baby can be discharged. But if by chance, second day, third day, everything things are going worse, then you rethink, okay, now this symptom can't be looks like meconium. So let me now think of sepsis. So, as I think the people correctly mentioned, this baby neither requires a screen nor requires antibiotics. Okay. So the message is no, not all neonates require a sepsis screen and antibiotics are not needed. Meconium babies also may not need antibiotics. So this baby was healthy and discharged by 8 days of life. Coming to the second case, now this is a preterm, 32 weeks, 1.480. So very low birth weight baby, vaginally delivered, G2 mother, unbooked pregnancy. Mother had some risk factors for sepsis, leaking PV for 48 hours, a slightly high count, neutrophilic predominant, 90%. Baby has cried immediately after birth. Apgar score is 6 and 8. Respiratory distress score is 4 by 10. Okay, so baby is transferred to NICU, radiant warmer, TABC looks good. Again, preterm baby with distress, so they started CPAP. Circulation, CFT looks good. Pulses are very well palpable. So again, who wants to type what needs to be done next? Sepsis screen, yes, no. Antibiotics, yes, no. What is the choice? Is this baby symptomatic, non-symptomatic? One or two people, please type. So we can go ahead. So this is a preterm baby, 32 weeker with respiratory distress. What you can just write what is practice in your unit also. So it need not be what you believe. Whatever is the current practice in your unit, wherever you all are training, that also you can write. So somebody has written sepsis screen, yes, antibiotics to be started after sepsis screen positive. Okay, good. So that is one possibility. So again, like I said, it's very simple, straightforward. Just look at the three-pronged approach that I said. Does this baby have risk factors for sepsis, antenatal? Yes or no? Yes, no? There was 48-hour leaking PV. This baby is preterm. So there is, definitely a risk factor. Second major factor is this baby symptomatic. So again, I look in my head, 32 weeker with a low grade CPAP, probably expected. So I don't blame this symptom on the, on the sepsis. I blame this symptom of distress on prematurity. So I would call this baby as not having any unusual symptoms. So I do need my third help, which is the sepsis screen. So they have written the same thing, two risk factors, VLBW, prolonged rupture of membranes. So they did send a sepsis screen. So it looks like TLC is good, more than 5,000. ANC neutrophil is good. CRP is less than 10. IT ratio is 0.3. Micro ESR is 10. So it is overall a negative sepsis screen. So what do you want now? Does this baby need antibiotics and can we start feeds? That is the second question. So can you type quickly? Antibiotics, yes, no? I think somebody has written already. One person has written antibiotic only if sepsis screen positive. So that is the right answer. So this baby has negative screen. So you can wait on the antibiotics. What about feeds for this 1.48 kg? Should we keep NBM for 1 or 2 days or should we start feeds? Your nutrition class is over. Feeds or no feeds? Who wants to feed this baby? Start feed. Okay. So Rachita says start feed. So the key was given in the question only, no, that the hemodynamic status of the baby is good. The baby is not on any inotrope, looks pink. So baby can be started on feeds. So antibiotics need not be started because the baby was stable on CPAP. And again, I highlighted the point that because the symptoms were not related to sepsis. So if you found that the symptoms are there, if that baby also was like lethargic, not active, then that becomes a symptomatic baby. So then you don't need to wait for the culture report. You don't need to wait for a sepsis screen. You can start antibiotics straight away. But this baby's symptoms were only related to prematurity. So that was not an indication to start antibiotics by itself. Plus our sepsis screen, which we sent, came negative. So this baby could be watched, monitored in the NICU, and we could avoid antibiotics. So came some other points also highlighted that for such a VLBW baby or even, stable older baby, you can start KMC even with CPAP. Mother was counseled, should be counseled for expressing breast milk from day one. preferably prior to delivery so that she's mentally prepared that she has to pump after. And by the time, the day 4, the baby received complete mother's milk and breastfeeds were possible by 33 weeks and the birth weight was regained by 8 days. So what happened to case 2? What was the final outcome? Discharged after 2 weeks. So 34 plus 2 weeks. So it was a very smooth discharge. Without any antibiotics, without any infections, this baby could be managed. Coming to case 3, again another preterm baby, very similar, 32 weeks. This is 31 weeks, 1399 grams at birth. Primipara, unbooked pregnancies, steroid 1 dose. But this is an LSCS due to antepartum hemorrhage. Previous one was due to leaking per vaginum. So this is due to antepartum hemorrhage. So maternal risk factor for sepsis, mother did have fever for 2 days, had a very high TLC count with neutrophilic predominance with foul smelling liquor. This baby did not cry after birth, but cried after initial steps. Apgar score was 5 and 8, and the respiratory distress score is 6 by 10. On transfer to NICU, the TABC is maintained. Temperature is cold, baby is in cold stress. Airway breathing secretions are cleared, baby is on CPAP. 6 by 40%, 93% maintaining. Circulation shows a little bit of tachycardia with slightly poor perfusion and has needed a saline bolus. So again, what do you want to do next? Should we do sepsis screen? Should we start antibiotics? This is becoming more interesting. So somebody please type now what do you want to do for this baby. This is a 31 weeker, 1399 grams baby. So who wants to send a culture? Who wants to send a sepsis screen? Please type in the chat box. Who wants to monitor? Who would like to start feeds? Any thoughts? You saw the history, no? The baby is having some distress, is stable on CPAP. Achha, somebody wants to see the case again.
Yes,
So I will
again,
quickly
yes.
go through the case again. So this is a 31 weeker baby, 1399 grams at birth. This was a section was done for antepartum hemorrhage. Mother had fever for 2 days, high TLC count, 80% neutrophils, and foul smelling liquor. The baby did not cry after birth and had moderate distress. So RD score was 6 by 10. And in the SNCU, the baby was noted to have poor circulation, so needed a bolus. And CPAP requirement is 40% oxygen and PEEP of 6. And there is some cold stress. So the question here is that should we send a culture? Should we start antibiotics? Should we start antibiotics? Okay. So Nandini has answered
Dr.
sepsis
Yeah.
is to be
So Dr.
sent.
Nandini has replied, sir, septic screen is to be sent and based on reports, antibiotics to be given.
Yeah. So that is what we did for the last case, Nandini. So that is a fair response. But this baby, like I said, no, from three-pronged approach, what is there? We had a risk factor for antenatal sepsis, yes or no? Yes. Fever for 2 days, maternal tachycardia. Secondly, is the baby symptomatic for sepsis? So for this case, the answer is yes, because a preterm baby who's 31, 32 weeks, you expect the baby to have RDS, but once you give a little bit of CPAP, that baby improves. This baby has temperature instability. This baby needed a saline bolus for poor perfusion. This baby didn't cry after birth. So there were some extra features which makes me worried that this is, a problem. So this baby already has qualified for your blood culture, antibiotic, sepsis screen all at once. The reason why I'm saying this is because the sepsis screen also would take 2-3 hours for the report to come back. So here the question is that even before the sepsis screen, you know that because the baby is symptomatic and sick, this baby will need antibiotics. So here you can start antibiotics simultaneously. Just take the culture blood labs and immediately start antibiotics. Let the sepsis screen come. That may not change your decision in terms of treatment. So this baby was again having 3 risk factors: VLBW, foul smelling, fever. Baby has features of shock. So the baby was symptomatic. Sepsis screen, again, like I said, no, it was positive. The TLC was less than 5,000. ANC is low. IT ratio, so the positive sepsis screen. So baby was started on first line antibiotics and cultures were sent. But again, like I said, if you want to know the perfect answer for this case, you don't need to wait for the sepsis screen because already 2 red flags are there. The baby is very symptomatic and there is a severe risk factor. So you can start antibiotics and send the sepsis screen at the same time. Now comes the difficult question. Okay, you have started antibiotics. How long do you want it to continue? So again, like I said, no, this is a symptomatic baby. So we discussed that during the presentation before. If you are only starting for prophylaxis or for risk factors, you can give it a very short course. So for 2 days, 3 days, say once the culture comes negative, this baby is symptomatic. So if the baby responds very nicely to your antibiotics, number one. Number two, if your culture comes clear, then you can give a short course, which is a 5 to 7 day antibiotic. And if your culture comes positive, then obviously you need a CSF or a lumbar puncture, and you need to prolong your antibiotics for longer. Hmm? So this baby's positive sepsis screen, stop earlier if the culture is sterile and the baby is well. If the positive blood culture is there, then 10 to 14 days. Otherwise, like I said, 5 to 7 days. Hmm? So what about the feeding? So would you like to feed this baby or wait for this baby? So again, feeding is related to the other organs health. So if the heart is happy, lungs are happy, then you can feed. So this baby had poor perfusion. They needed a bolus. The baby was having lot of oxygen requirement. So you need to assess that after reversal of shock. So once the shock is corrected and the baby is stable, you see that the baby is moving, active, passing urine means the organ perfusion is good. You can start what is called as minimal enteral nutrition via OG tube. So you can start that at 10 to 20 ml per kg per day, mother's milk only from the OG tube. And once the baby is better from all aspects, you can go up on the feeding as per protocol. So this baby reached full feeds by day 6. So this baby was monitored on CPAP, was weaned to weaned to CPAP from day 8, room air on day 9. Feeds were started on day 1 and hiked, and by day 6 baby reached full feeds. KMC was initiated from day 3 once the shock and everything was reversed. Mother was counseled early on antenatally, postnatally for breast milk expression, and complete mother's milk was possible from day 6, and breastfeeding by day 18, and regained birth weight by day 9. So discharged on day 22. So learning was identification of early signs is important. Supportive management is important in shock. So you need to have a holistic approach. You need to see all other organs. So coming to case 4, 37 weeker, 2.2 kg baby, vaginally delivered, G3 book pregnancy, brought to the hospital on day 5. So this baby was home and now is brought to the hospital on day 5 with a respiratory distress. So the score is 4 by 10, and there is history of fever since the last 3 days with maximum documented fever being 38.5. And the baby is not accepting feeds. The baby is on CPAP, 30% and 5 PEEP. TABC is maintained, but the baby is in cold stress, started on CPAP, and with CPAP, slowly the oxygen has come up to 92%. Circulation is good, peripheral pulses are well palpable. So first question is this early onset or late onset? When has the baby come? Baby has come on day 5. So is this early onset or late onset? So unlike the previous cases, this is a late onset sepsis. So this has come later. So again, what do you want to do for this case? I want some answers in the chat box. So for this case, should we start antibiotics or should we wait? Rachita, correct. This is late onset sepsis. Do you want to start antibiotics or just wait out, see the sepsis screen and then decide? What would you like to do? So again, this case, you have to send the culture before starting antibiotics. But this baby from all angles, like I said, no, in a three-pronged approach, the main prong remains to be the clinical picture. This baby has all the signs of infection. There is fever, there is distress, which is late, not from birth, but has started late. Temperature instability is there. So this is a very clear-cut picture of late onset sepsis. So again, you can take the culture, send the sepsis screen and simultaneously start antibiotics. Let us see what happened. So when this X-ray was done, there were fluffy infiltrates like a community acquired pneumonia in the lung. Blood culture was taken and a lumbar puncture was planned. So this was a case of late onset sepsis, probably community acquired pneumonia based on the X-ray. CSF examination was normal because remember this is a late onset sepsis. So ideally the CSF examination has to be done prior to starting antibiotics. And this was the sepsis screen. Low TLC, so low leukopoint. Look at the CRP 28 and micro ESR is 25. So this was again a positive sepsis screen. But like I said, because this baby was so symptomatic, we had started antibiotics already and we had already done a lumbar puncture and started antibiotics. What did the blood culture grow? E. coli. So how long do you want to give? So this is a culture positive late onset sepsis, no meningitis. So can somebody type how long you want to give? And it's a gram negative bacteria. Do you want to give for 1 week, 10 days, 14 days, 3 weeks, How long do you want to start antibiotics for this baby? Culture positive blood, 14 days. Correct. So this is a gram negative picture. So 14 days is the right answer. No meningitis. So not needed. We don't need to give it for 21 days. So 14 days is the right answer for antibiotics. So this was a blood culture positive sepsis. So 10 to 14 days, but gram negative, like I told you before, probably 14 days is a better option. And antibiotics were given for 14 days. What about the feeding? This baby was having good perfusion. The moment CPAP was started, the baby, responded well. So feeding could be continued. Because the baby was very lethargic, probably give it from orogastric tube initially. You don't want any aspiration. And once the activity improves, you can start oral feeds. So this baby was monitored on CPAP and weaned on day 4, room air by day 5. So learning late onset sepsis or any sepsis, always send blood culture prior to antibiotics. Late onset, always perform a lumbar puncture. So now those were the cases. Just a few things about prevention of infection. So always remember that the bacteria which are there in the environment or what causes sepsis, they have, they are finally going to enter from the baby's skin or the baby's mucosa, or we are directly putting it in the baby's blood through an IV or an injection. So always remember that those procedures that we do or those handling that we do, that remains the most important. The floor cleaning of the NICU or the hospital will happen, the walls cleaning will happen, the incubator cleaning will happen. But finally, the bacteria, going from the incubator wall or the warmer wall into the baby from our hands. So they can't jump. E. coli can't jump from the warmer into the baby's body, right? And even once it reaches the baby's body, it has to enter the blood. So either there should be some skin breach or the baby should be premature with immature skin, or there should be an IV poke where, the skin is already injured, or through a mucosa because of RT, there is, gastric mucosa damage, or a urinary catheter, or a central line where we are actually breaching the baby's defense. That is how the bacteria enters. So it is not very difficult to, prevent it. It is not rocket science. It is actually very simple things that prevent infections. And hand hygiene, hand washing remains to be the primary thing. Because, like I said, even if the warmer has a bacteria, if I touch the warmer, but if I'm doing a very good hand hygiene, then the bacteria is gone. So I can still touch the baby. So we should always think of infection prevention from the baby to the outer side. Okay, so that way the more priority things will be taken care of. So nursing environment should be clean, adequate ventilation, temperature, avoid overcrowding. There should be a good nurse to patient ratio. Procedure should be very strictly, monitored. Aseptic procedure should be done. Minimizing procedures is the best option. So what we call as bundled care. So, preparing injections at one time, having a separate nurse to give injection, having some privileging system. So if, in our unit, if there is a new doctor or a new nurse, they can't immediately give medicines through a IV line. They have to first observe, learn, train. And then after that, they can do IV line, but they still can't do injections through the central line. So having a sort of training mechanism, education is good. And the key behaviors are, like I said, the most important is hand hygiene. Second is environmental, keeping the environment and medical equipment clean, and also healthcare waste management. So all these things will help in preventing. We know the WHO 6 steps technique of hand hygiene. If not, please go through this. It is very important. Very commonly asked in exam and something that, examiners don't like if students don't answer. So please go through the 6-step hand hygiene and practice it every day so that it becomes a habit. It can be done with a soap and water, or it can be done with a alcohol chlorhexidine hand rub. So if there is visible soiling, like if there is blood or stool, then it is better to use soap and water. If it is not in between touching babies, even a sanitizer is equally efficient. And these are moments of hand hygiene. So the previous slide was showing the steps. This is the moments, like when do you want to do? So 5 moments of hand hygiene: before touching a patient, before clean or aseptic procedure, after body fluid exposure, after touching a patient, and after touching patient surroundings. So even after touching a monitor or something, we need to do a hand hygiene approach. And this asepsis is newborn is like a common chain. It should be at every point: at birth, during transport, in the NICU, during injections, during OGT insertions, things that we feel are non-infective. Even milk infections can cause, stomach infections, which can become sepsis. So milk handling is important, proper pasteurization if it's a milk bank, proper storage of milk if the mother is expressing and bringing, sterilizing the containers. So every step is important because the babies are prone for infection. They have a very, very low immunity. So we should be sure that we are extra cautious about all the things. At birth, we maintain a clean area, standard precautions, avoiding unnecessarily handling, clean resuscitation equipment, using clean sterile scissors to cut the cord, starting breastfeeding as early as possible. There should be a protocol like how many times in a day the walls are going to be cleaned, the warmers are going to be cleaned. Having a proper, we have a proper handout written in the NICU that what chemical to use for what trolley. So some chemicals for, we use glutaraldehyde for something, we use bacillol for something. So, what all cleaning things are there. For that, every unit should have a ready protocol. This is the frequency that you want us to clean, and this is the chemical that you should use. And always use sterile water in nebulizers. Keep disinfecting your equipment. Whatever disposables are there, do not reuse it. And inside the NICU procedures, device-related infections, CLABSI means central line associated bloodstream infections. So they are common. So we need to be very careful. And aseptic non-touch technique is there, which means that always wash hands effectively. Never contaminate the key parts. Like if there is a connection between the central line and the hub. So whenever you disconnect it, always use a sterile alcohol swab. Preferably don't disconnect it. Keep it, like a closed line. When one person is handling that key part, somebody should supervise and always take in non-infective or sterile precautions before handling such things. Feeds are, underrated. So breast milk has lot of IgA, lot of immunological compounds. So they should be encouraged. Early feeding is known to reduce sepsis. Not only it reduces your parental nutrition, but by the baby's immunity also, it helps to reduce sepsis in all ways. Avoid formula milk. Again, big cause of, stomach infections, diarrheas. So, and feed should not be prepared in patient care area. So there should be a separate area for collecting, storing mother's milk. Wherever other feeds are needing to be prepared, it should be in a separate clean area. When do you need isolation? So isolation is normally not needed in the NICU unless there is an outbreak or unless there is a bacteria that is not common to the unit and there are, preterm babies nearby. If you are worried that there is some chance of droplet spread, so if there is a neonatal exposed to chickenpox, that would definitely need an isolation. And neonates who are extreme preterm, they need to be sort of, negatively isolated, means they need to be in a separate. So most NICUs have a separate ELBW or extremely low birth weight area where their immunocompromised babies are there. Many units in India have a separate outborn section so that outborn babies can have an infection so that they are directly not coming in contact with these babies. But definitely, if you know that there is some MRSA or a resistant bacteria, or there is an outbreak of, some bacteria in your unit, then you immediately need to isolate and cohort. And the nursing team also should be separate. Like that nurse can't then come in that area where other small babies are there. So the take home message again, like I would say, sepsis remains to be the most common problem and the thorn in our flesh as neonatologists. In India, currently neonatal mortality hugely is due to sepsis. And even if it doesn't cause mortality, it does cause a lot of morbidity, brain injury, prolonged hospital stay. So it is very common, very, very important. Remember the three-pronged approach that I said? Go very much in depth in history for risk factors of infection. Is anybody in the house sick? Was the mother sick? Why did preterm labor start? How long did the fluid leak? Was it foul smelling? Was there any examination? So detailed history for risk factor assessment. Most important, baby symptoms. Is this baby symptomatic? General symptoms, activity, perfusion, individual system, breathing fast, perfusion poor, feed intolerance, urine plus or minus, drowsy or lethargic. So go for symptoms and then the sepsis screen and culture. So this three-pronged approach will, help you not miss many sepsis. Follow a very strict antibiotic stewardship because it is very easy to go the other way. So keep checking your own policy, update it, make sure somebody is supervising it, and prevention is the key. If infection is prevented, it's a whole game changer. The babies who go home without infection, long term when they come for follow-up, they are all hale and hearty. And short NICU stay, less cost, less antibiotic use. So overall, it is a very good thing to have no infection. So prevention remains to be the key. We can have some questions for 5 minutes. Please type your questions if there is anything. Or if somebody wants to speak out also, they can unmute and speak. I'll stop my screen share. So any questions for sepsis? Have you all seen any experience from your end? What was, what antibiotics you all use? Do you want to type what an antibiotics is first line in your unit? And why is it? Apnea is possible due to sepsis. Abhishek is asking, yes. Apnea is very much possible due to sepsis. So late onset sepsis for preterm babies, we very commonly see apneas. Even for term babies, apnea can be a sign of sepsis. So there is something called as apnea of prematurity. But if suppose a preterm baby is having frequent apneas, which is unusual, or it is baby was stable for 5-7 days and after that apnea start, it is definitely considered a symptom of infection. And a term baby should not have apnea. So apnea is very much in the list of common symptoms of sepsis. So I wouldn't call it like an uncommon symptom. Apnea is a common symptom of sepsis. Anyone else? Any other questions? You can type or ask, whatever. So how commonly do you see sepsis in your unit? One per week or many per week, one per month? Does anyone want to type? Can you type and share how often you see? Is it common in your unit, uncommon in the NICU? Neonatal sepsis only, not other one. It could be outborn referred. One per day, yes, very common. I'm not surprised. We also get very, common cases of infection. So now what you have to do, Abhishek, is that once you go, you have to think of the three-pronged thing. So maybe one per day is what sepsis is written on the diagnosis in the file. But you look at these three factors that I said, that what were the risk factors, what was the sepsis screen, and what was the symptoms. So once you have this three, then probably this one per day might change. Maybe we are over-diagnosing or missing subsepsis. So I think see what, with this systematic approach, if you can change this sepsis, some is like a sepsis, that some doctors feel, or is it our fear, or is it truly a sepsis? How much of one per day, just out of curiosity, is culture positive? Do they all culture positive sepsis one per day, or are they clinical sepsis? More of clinical, yeah, correct. So like I said, culture positive sepsis, there is little problems with the culture also, but partly
More of
problem with us is in which we overdiagnose sepsis also, because that is a treatable thing, no? And as doctors, we never want to miss anything that is treatable, which has a treatment. Correct. Any other
clinical.
questions? Go ahead, Gunjana, you were saying something?
Yeah. So I was just telling that for the residents, it's actually important to know when not to start the antibiotic. So basically, rampantly starting of antibiotic should be actually stopped. Just as Sir also mentioned that there is no point starting the antibiotic haywire when even you do not have an indication. So that should be taken care of because you all can start antibiotic very well, but when not to start antibiotic, when just to hold yourself is actually much more important. This is just why I wanted to ask.
Right. There is nothing like prophylactic antibiotic in the NICU ever. So always remember that. There is no prophylaxis for antibiotic.
There are no more questions, I think, sir.
Yeah.
Then,
Okay. So we can end the session.
thank you. Yes. Thank you, sir. Good night. Sir. So there's
Thank
another
you.
question which has just popped up.
Huh.
CRP, procalcitonin are useful for early onset sepsis.
So, uh, That is actually like a Pandora's box. So I'll keep it very short. So CRP and PCT again are acute phase reactants. They have very poor positive predictive value, which means that they can rise in any number of things. They are non-specific. Sometimes even a delivery stress can make it rise. So to answer it in one line, that they both are not useful for early onset sepsis. And most units are slowly stopping to do it at all, especially as a single parameter. If you combine it with total count and neutrophil count and IT ratio and CRP, then maybe it might, increase the predictive ability, but it still is not a great tool. So I would not, routinely do it for diagnosing it. And especially I would never do it by itself and rely on it. So it can be done as a adjunct along with a panel of things, but not useful. Hmm. The last years, I think JAMA, there was a big paper, with a title saying that CRP is useless for early
Crap.
onset
It
sepsis.
is a crap.
Yeah.
Sir, is new marker called pre-sepsin a great one?
Huh. So always remember, Abhishek, that whenever you have something like a news flash or a thing, then, if it was really good, then everybody would be using it. So again, like I said, that there are a lot of research tools, some, early markers and some very early markers. So they are not, so the only great tool will be a direct test, as I mentioned in the diagnosis, which is where you are actually picking up the bacteria, which is blood culture. And the other direct thing is a PCR test, where you are actually detecting the bacterial components, which we didn't discuss. So these are the direct tests where we are catching the bacteria. Everything else is indirect. So yes, as it's these are all upcoming things. They might, catch up pace, but we are far from calling precepsin as a great marker. So it is not really practically used in units. Anything you
Plus
want
the
to add,
cost.
Gunjana, for that?
It is, yeah, yes, sir. It is just a cost also. These investigations are not cost effective. You
Yeah.
cannot do it for the large, huge number of the population that we are catering to with
Hmm.
no proper literature available on them.
Hmm. True.
Another
And
question, can we use single antibiotic in
yeah.
meningitis
Hmm.
uh,
Yes,
if
very
blood
much you
culture
can.
shows
So the
sensitivity?
example, especially that you have shared, is that culture shows sensitivity to Miro amica vanco. So you have to choose what antibiotic, the sensitive one with a good CNS penetration. So here in this case, meropenem has excellent CNS penetration. So if you use the anti-meningitic dose, 40 mg per kg per dose every 8 hours, so the higher dose, it will be, penetrating the CSF. And like I said, one precaution in meningitis is you have to look for complications. So there should not be any subdural empyema, no ventriculitis. And if you feel, and most cases of meningitis need a repeat, lumbar puncture to ensure that there is clearance. So if we have all of that, then a single antibiotic is absolutely safe. Is absolutely safe. Okay,
I
I
think there are
think there
no
are
more
no more
questions.
questions, then we can end the session.
Yes, sir. Yes. Thank you, sir.
Yeah.
Good night,
Okay.
sir.
Thank you, everyone.